So coming to the short revision of the CVS, RS, abdomen and critical care patients. So when you get examination of CVS, the stem can be elderly patient, midline sternotomy, audible, metallic click, pansystolic, do CVS examination. So you do inspection, breathlessness, sinuses, pallor, surrounding oxygen, medication, what is there, you have to see scar, midline scar, chest wall deformity, pacemaker, box, hands, arm, clubbing, splinter, hemorrhage, peripheral cyanosis, radial pulse, rate, rhythm, retroradial delay, aortic dissection, collapsing pulse, aortic regurgitation, BP, face and neck, eye congestion, xanthelisma, mouth, central cyanosis, high arch palate, GVP, and all that. Then inspection, this is the systemic inspection of the precordium, scar, chest wall movement, visible apex beat. Palpation, palpate the apex beat, location, character, hues, left ventricular hypertrophy, thrills, palpable. Then auscultate the metallic click, mechanical wall, pansystolic murmur, mitral regression. 4 areas. So mitral area, left fifth intercostal mid clavicular line, tricuspid, left lower sternal motor, fourth intercostal base, pulmonary, left second intercostal base, aortic, right second. So radiation to the axilla, mitral degradation, radiation to the carotids, it will be aortic stenosis. Posterior chest and legs, lung basis crackles, sacral edema, peripheral edema, calves and DVT. Complete examination when you do peripheral vascular, ECG, echocardiography, and anticoagulants. Then the questions will be, what is the diagnosis? You get a pansystolic murmur, mitral regurgitation, radiating to the axilla. Investigation, pre-operative, resting ECG, echocardiogram, INR. Management, general check, local policy, consult hematologist. Lower thromboembolic risk, stop warfarin, 5 days, start low molecular weight heparin. So high risk, low risk, if it is there, then you can start low molecular heparin. High risk stops warfarin 5 days, low molecular enoxaparin, stop 24 hours before. So this is a bridging therapy. So restart warfarin INR once from range. Patient presents with fever, 5th post-operative day, cause infective endocarditis. Whom to inform? Infectious disease, cardiology, CVT or surgery, microbiology, anesthetists, ICU, GP, public health, notify coroner. Precautions. In such case, inform theatre team, anesthesia, inform cardio team who perform operation and response. Consider wall dysfunction, regurgitation, obstruction, and short burst. Consider prosthetic wall infection, consider pacemaker infection, use sterile techniques and resuscitation equipments. So what about the respiratory system examination? COPD patient for leg to hernia surgery, repair, perform RS respiratory examination. I would like to examine the chest and ring. Appearance, breathlessness, cachexia, pursed lips, use accessory muscles, oxygen, whether patient is taking this, finger clubbing, nicotine, respiratory effort, cyanosis, peripheral, hands and arm clubbing, tar, peripheral cyanosis, radial pulse, face, neck, conjunctival pallor, central cyanosis, tracheal deviation, neck, chest examination, posterior, anterior, apex beat inspection, barrel shaped, scar, thoracotomy, asymmetric deformity, palpation, chest expansion, tracheal deviation, tactile vocal frequency, percussion, hyperresonance, COPD, dullness in consolidation, auscultation, decreased breath sound, wheezing, prolonged expiration, crackles, legs, peritoneal edema, DVT, sacral edema, complete examination, access to saturation, inspection, COPD. Question answer: COPD based on the age and smoking, differential acne, heart failure, pulmonary edema, neuroma, CA lung, and all that. Whom to inform? Physicians, concerns, or surgeon. Further investigation, chest X-ray, assess for pre-operative pneumonia, rule out underlying lung malignancy, risk factor for COPD, underlying surgery, pre-operative measures, smoking cessation, chest physiotherapy, bronchodilators, steroids. Intraoperative measures, prefer open surgery versus laparoscopy, avoid GA, muscle relaxant, use regional anesthesia. Post-operative measure, close monitoring, possible complication, pneumonia, ARDS, basal electrolysis. So this was about the respiratory system. So then you go for the abdominal examination. So you get different for abdominal examination. You may get different stations. Then you see in general examination, inspection, appearance, distress, cachexia, surrounding, analgesic, skin rash, hands and clubbing, coilonekia, stresses, face, neck, pallor, jaundice, mouth, stomatitis, glossitis, sweet hepaticus, neck, cervical lymphadenopathy. Abdominal inspection, distension, scar, masses, hernia, visible peristalsis. Palpation, ask the patient if he is pain, tenderness, guarding rigidity, deep palpation, masses, organomegaly. Percussion, liver spans, spleens, shifting dullness, auscultation, bowel sounds, complete examination, hernial sites, question and answers. Then left iliac fossa pain, diverticulitis, IBS, constipation, C rectum, volvulus, full blood count, investigation, ESR, dehydration, IV contrast study, urine microscopy, acidosis, lactate, imaging, abdominal X-ray, sonography, CT scan. CT shows sigmoid wall thickening, one locule of the gas, management sample for the culture sensitivity, empirical antibiotics, observation, CS report, DVT, prophylactic analgesic. If no response to conservative treatment, peritoneal drainage, Hartmann surgery. If it is a case of acute cholecystitis, differential cholangitis, pancreatitis, peripheral appendicitis, right upper quadrant pain, fever, jaundice, left. Investigations. What is Charcot's triad? Right upper quadrant fever and jaundice. Investigations: liver function, lipo, GGT, imaging, abdominal ultrasound, MRCP, thickened gallbladder, gallstone, free fluid in the abdomen. If clinical blood finding, acute cholecystitis, ultrasound normal, HIDA scan. So ultrasound is normal and clinically suggestive of cholecystitis, HIDA scan. Dilated CVD, ERCP, complication of empyema, gangrenous, initial management, IV fluid, analgesics, definitive management, laparoscopy, open surgery. About the regime: first generation cephalosporin, metronidazole, third generation. Appendicitis, differential acute appendicitis, Meckel disease, peptic ulcer disease, UTI, ischemic bowel disease, gynecological causes, ectopic, PID, salpingitis, complicated torsion of testes and metal shimmers. Investigation: lab, urine pregnancy test, full blood count, inflammatory markers, liver function test. Imaging: ultrasound, CT, more specific, and surgical management, open laparoscopy, thorough peritoneal search for the pathology: female, PID, males, mesenteric adenitis. Complication of appendicitis: wound infection, intra-abdominal abscess, adhesions, bowel adhesions, bleeding, injury to the surrounding structures, negative appendicectomy, appendix removed, but no pathology found. Histology: most common cause of lymphoid hyperplasia. If appendix appeared normal during surgery, perform thorough search for the remove the appendix because maybe histologically confirmed. So painless: if the patient is having painless jaundice, type of the jaundice, pre-hepatics, hemolytic, sickle cell anemia, glucose deficiency, spherocytosis, Gilbert syndrome, Crigler-Najjar syndrome, hepatic alcoholic liver disease, viral hepatitis, post-gallstone glazing questions. Investigations done: full blood count, clotting, screen, amylase, hepatic investigation, imaging, ultrasound, and CT scan. So this was about the abdominal. Now if a patient, you get a stem for critical care examination, pre-operative anastomotic leak or pulmonary, post-operative either anastomotic leak or post-operative pulmonary embolism. So patient is talking, means airways pattern, breathing, general inspection, oxygen, check trachea, pulse oximeter, respiratory rate, expansion, percussion, circulation, neck, carotid, JVP, refill, BP, circulation, withdrawal, disability, exposure, lower limbs. Then the questions come will be: generalized peritoneal falling, leak of the anastomosis. So anastomotic leak, subphrenic collection, mesenteric ischemia, intra-abdominal abscesses, differential pulmonary embolism, myocardial infarction, atelectasis, shoulder tip pain, diaphragmatic irritation. Investigation: blood, ABG, blood culture, imaging, chest X-ray, AP, abdominal ultrasound, CTPA, pulmonary radiography. Management: monitor, inhale power, nasogastric tube, and all that. IV fluid, resuscitation, crystalloids, antibiotic. Hartmann's question answer for pulmonary embolism, pulmonary myocardial infarctions, investigation CPPA, chest X-ray, D-dimer, ABG, serum alkalis for the ECG, S1Q3T3, Miss-Vican syndrome, deep lead 1, Q and 3, and right ventricular strain pattern, excess deviation. How to prevent pulmonary embolism: early mobilization, TED stockings, pharmacological heparin. Management is less than minor, therapeutic dose of subcutaneous heparin followed by warfarin. Massive thrombolysis, low molecular heparin dose, prophylactic 40 mg OD subcutaneously, therapeutic is 1 mg per kg BD, unfractioned heparin 5000 international unit, therapeutic loading is 80 international unit per kg, maintenance is 180 per hour. APTT has to be 14 seconds.